All right. Can everyone hear me okay? This is Anu, Chef. Dr. Holloway, are we good to go? I'm going to go ahead and get started because it's 11 o'clock.
Dr. Seth, I think we certainly can. I don't see where our executive director, Lynette Rose, has been able to join us yet. I text her.
Oh, okay.
We may just maybe need to maybe switch the agenda with the presentation going first if she hasn't joined us at that time. That's your decision, but that would be nice.
I'm happy to wait just another minute. I see that there's a lot of people that are still trying to come in. So let's just give it another minute and let everyone get settled.
Okay.
Yeah, let's do that. Because I certainly want her to be able to be there for the presentation as well. So
certainly.
Yeah.
Lynette, have you been able to join us? I was trying to look at the participant list.
Hi, Dr. Holloway. Good morning. Yes, I am on.
Good morning. Thank you.
Good morning.
good morning.
My apologies. I was wrapping up with the commissioner. Sorry about that.
We understand, ma'am. We understand. Dr. Seth, it's your call, ma'am.
Yes, absolutely. Thank you so much. I know you're jumping from one video call to another. Thank you, Lynette. That's kind of what we all do, I guess, these days. So welcome. I'm going to go ahead and get started because we have a guest speaker that wants to present some information. So I think it's been a year now that we've been doing this virtually, and we've become pretty good at it. So hopefully someday soon we'll be able to get together in real person. I can't say I don't like the not having to drive downtown though, but anyway, our first order of business is to adopt the agenda, and we're going to do this the way we do it for video calls, which is I just need a motion to adopt for the adoption of the agenda.
This is Dr. Sukas. I move that we adopt the agenda.
Thank you. And then are there any opposed?
Who's Dr. Alexander? I'll second the motion.
Oh, thank you, Dr. Alexander. I'm just trying to move it right along. I appreciate that. Any opposed? If not, I would like to go ahead and adopt the agenda. I'm going to move on to the minutes. I hope everybody got a chance to read the minutes from last time. I need a motion to approve the minutes.
So moved, Alexander.
A second.
Second
From
Sukas.
Laura Colbert.
Thank you. Is there any additions or changes that anyone has for the minutes? Any? If not, then I am going to take that as a unanimous. The minutes are approved. And then I'm going to move right on to our executive director, Ms. Rhodes, if you can give us the report on the medical assistance plan.
Hi, good morning, everybody. Happy Wednesday. I do have a few updates. Thank you so much, Dr. Sheth. So I will move through these relatively quickly. I would normally have prepared a PowerPoint, but just due to a number of competing priorities, I did not have an opportunity to do that today. However, I will talk you guys through where we are. So in terms of the first update, we see here Georgia waiver updates. We actually have two waivers that I wanted to update the group on today. So the first is the postpartum 1115 waiver. So for those of you who may not be aware, pursuant to this waiver, again, the postpartum, we will be extending postpartum services for a period of 6 months. And this waiver has been approved by CMS. In fact, on this Friday, we did send to them our acknowledgement and acceptance letter. So that seals the deal. So we do have now an approved 1115 postpartum waiver. This waiver will be implemented on July 1. So that is the go live date, July 1. And so, this is going to be great news for the state of Georgia. As you all are aware, we have had, some real concern with mortality and morbidity. And so this will help us to be able to improve the results in the state of Georgia. So looking forward to moving forward on July 1. The second waiver that I wanted to talk about is pathways. The 1115 pathways to coverage waiver. So I'm sure that you guys have heard about this. This is our waiver where we are seeking to provide Medicaid to those individuals who are between ages 19 to 64, whose income is up to 100% of FPL, and individuals who meet certain qualifying activities. And so in February, we received a notice from CMS indicating that they had concerns with the qualifying activities component of the waiver. And so in a number of other states, CMS has struck down those provisions. And the concern is around conditionality, which means that they are concerned with us taking the approach that someone has to meet certain qualifying activities as a condition to receiving Medicaid. So that's in a nutshell their concern. So we did respond back to them in March. We are still waiting to hear back from CMS on next steps. However, while we are waiting to hear back from CMS, we continue to work towards our implementation date of July 1. And so this entails us making a number of changes to the gateway system, which is our integrated eligibility system, as well as the GAMMA system and our policies and procedures. So we're continuing to work through that process and we'll be ready, one way or the other, we'll be ready to go on July 1 of this year. So we'll keep you posted in terms of next steps. There are quite a few decision points, that need to be made. And so, one of the questions is, of course, what happens on July 1 if we don't hear back or haven't heard back from CMS? What is the state's plan? So we're still talking through that today. We're also setting a go, no-go date in terms of when we're going to push the system changes into production. So talked about that with the commissioner this morning. So we'll continue to keep you all posted on the status of the waiver. So those are our two waivers and the updates on where we are. Moving on to the second item, the legislative update. So I think the biggest news is that we survived. This was probably one of the fastest, most aggressive legislative sessions that I have seen in a while. And I've experienced many, but they moved very, very quickly this year. And so all of the, legislation has been signed by Governor Kemp. So we are completing our review. The one thing I will mention is that on last Thursday, we did present to the DCH board a number of rate increases. I hope that you guys were able to listen in on that, but if not, the board meeting presentation is available on the DCH website. Additionally, all of the public notices are posted on the DCH website. So if you don't have time to listen to the full-blown recording, you can definitely go and look at the public notices that were posted. And so I'll share just a couple of those with you. We did present to the board a request to do a 3% dental rate increase on certain dental codes. So we received initial approval from the board. We are going to go through our public notice process, and then we will re-present to the board for final adoption the results. We also presented to the board a request to increase 18 primary care and OBGYN codes to the 2020 Medicare fee schedule rate. And so we received initial adoption on that as well. The one very important caveat that I want to mention as it relates to the increase for the primary care and OBGYN codes is that that increase will only apply to providers who previously attested under the ACA. So it's very important that everyone understand that. This is not an across the board rate increase for all providers. It will only be for those providers who previously attested. We also did presented a rate increase for the waiver providers under our elderly and disabled waiver. And so that was a 10% rate increase that we presented. We'll be doing the second half of that for the independent care waiver program in June. So just stay tuned for more news there. We also presented out on an increase for the mechanical vent rates, as well as a few other, rate increases. So I'm sure, and I hope that was good news for all of our providers, but those were the things that came out of this year's legislative session and the Appropriations Act. We're continuing to review all of the legislation that has been signed into law and continuing to make those updates. So we'll keep you posted at our future. Moving down to the next update, which is the public health emergency update. You may have heard that the public health emergency has been officially extended through July. And this is the federal or the national public health emergency. So just want to make sure that everyone is aware of that. I know that sometimes there's some confusion because you have a state public health emergency, and Governor Kemp has rolled back or starting to roll back a number of those provisions that were put in place. But as it relates to the national public health emergency and the Medicaid program, as of right now, we're keeping all of our waiver provisions in place until further notice. The next thing that I will mention is lactation consultants. So we did receive funding to enroll lactation consultants. And so they are now a licensed provider in the state of Georgia. We will be enrolling them as an individual practitioner type. And we will be opening up certain codes for lactation services. So just stay tuned for more news there, but just wanted you to be aware that that is something that we are working towards. The next topic is the CMO merger. And so for those of you who haven't heard, the merger took place on May the 1st. So it has already happened. And the good news is that it rolled out pretty quietly and pretty smoothly. We are meeting with Peach State Health Plan every week. We have a touch point meeting with them, and we'll continue to do so for at least the next 6 weeks, just to make sure that everything is running very smoothly. They have, of course, received a significant increase in their call center volume, and that's to be expected. And that's a good thing. That means members and providers are calling in, they're asking questions and getting clarification. At a high level, Peach State is honoring all existing prior authorizations. So if you have patients who had authorizations that had been approved under WellCare, please know that Peach State is honoring those, so it shouldn't be any issues there. One area where we did have a lot of concern had to do with pharmacy and prescription medications. And so Peach State is granting 2 30-day refills on maintenance medications. They're monitoring that really closely. That's going well. They're also working with their providers to make sure that there are no issues with respect to contracting. So overall, it's gone well thus far. So, huge congratulations to Peach State and their team, as well as WellCare. They work very closely on the merger. They are also having daily rounds where they're reviewing those members who are in an inpatient status, just to make sure that no one falls through the cracks. And they're also closely monitoring the payment of claims. So if you have any questions regarding the merger, please feel free to reach out and we'll share with you any updates or direct you to the appropriate persons at Peach State Health Plan. The last thing that I will mention, and Dr. Holloway, I did not give this to you to add to the agenda, and that's mostly because it just came up yesterday, but I wanted to take a moment to talk to this group about it. And that is, we are embarking on a project with, it's called Lifeline. And in essence, it's a federal program that will provide free cell phones, free mobile phones to Medicaid and Peach Care for Kids members. And so we are going to be working very closely with the care management organizations, as well as DFACS, on getting the word out to our members, so that if there are individuals out there, who don't have a mobile phone, they'll be able to get one free at no charge. The only condition is that you be eligible for Medicaid or Peach Care for Kids. And so we will be seeking the assistance of our provider associations to help to communicate this out to the members. But just wanted to make you aware of this. We are very excited about it. It's your standard smartphone. So it's not anything that's, that anyone else wouldn't want. It will allow the member to receive text messages, updates about things like annual redeterminations, enrollment. And so we'll keep you posted, but just wanted to make you aware that that is a project that we're working on now. And so Dr. Sheff, Dr. Holloway, that completes my report this morning. And I'll pause to see if anyone has questions.
Thank you. That is a whirlwind. Thank you very much, Lynette. I'm going to open it up for questions.
Hi, good morning. This is Laura Colbert with Georgians for a Healthy Future. Lynette, thank you for all the updates. Really pleased to hear about the rate increases. Rate increases are always a positive move. So really excited to see the many that you guys are working on getting done right now. I do have a couple of questions. One is the 6-month extension of postpartum Medicaid coverage. Congrats to the department on the approval. So currently, because of the federal public health emergency, no one is losing their Medicaid coverage right now, correct, right? So will that'll essentially just be invisible for a little bit?
Correct. So no changes there. We'll continue to, maintain those individuals on the roll through the public health emergency. I may have shared with this group earlier. CMS did issue a letter to all of the governors indicating that the public health emergency would most likely and I'm using their terms, most likely continue through the end of the calendar year. And so if that, is the case, we'll continue to maintain those persons on the roll. So Laura, this should be, pretty much seamless to those members. Other than that, they'll now get an extra 4 months of postpartum services.
Great. Loved hearing that. And then my other question is about the non-emergency transportation process. My understanding is that kind of request for proposals process has started, but yep. Can you maybe catch us up on where that is and what the next steps are? Just curious.
Yep. Absolutely. So yes, we did issue, I think maybe about a week or so ago, the non-emergency transportation procurement. So that is now out. And so anyone that's interested in bidding on that may do so. Last week, we had a conference for those providers who may have had questions. This is our standard process. So it's just an opportunity for potential vendors or potential bidders to come in and ask any questions that they have about the procurement document that's been posted publicly. And then what we typically will do is respond to those questions in writing. So that bidders conference, that's the official name, the bidders conference did take place last week. And I know that our team is working on responding to all of their questions in writing. And then after that, next steps are we'll begin receiving the written proposals. We have a team of evaluators who will evaluate and rank those proposals. And then once we've made a final decision, we will issue a notice of intent to award and then go through, that final process. We'll see if there are any protests. And if not, then we'll do a final notice of award and then move forward with implementation.
Thank you.
Thank you. Any other questions? I have a question, if I may, regarding the lactation consultants.
Yes.
Should we, so individual IBCLC, they apply through the process for application, what would that be?
Correct. Yeah, so just like any other provider, Dr. Sheff, they would have to submit an application for enrollment. They will be credentialed, just like all other providers, to ensure that they meet, have the necessary qualifications, educational background, training, certifications, all of that. And as long as everything checks out, then they will be enrolled, and they'll have specific codes that they can bill, for as it relates to lactation services.
Perfect. So I guess we'll get more information about what those specific codes are once.
Yes.
Okay. Excellent.
Yep.
Any other questions from the group? Hearing none, thank you so much, Lynette. That was a lot.
Thank you.
It seems like each time there's more and more. So we appreciate all that you do to keep our state moving. Thank you.
Yep.
I'm going to move on because we have a guest speakers today. We have Abbott Diabetes Care. I'm going to just introduce the speaker today is Dr. Marie Frazita. I hope I said it correctly. You can correct me. She will be doing the presentation for Abbott today. She's the Senior Medical Outcomes Manager for Abbott Diabetes Care, and she's licensed as a nurse practitioner, certification in family practice, has an MBA in healthcare administration, and over 20 years of clinical experience with expertise in the field of diabetes, and his extensive experience in quality metrics, reimbursement models, and regulatory requirements. So with that, I'm going to turn it over to Dr. Frazita. Did I say it correctly?
You did. You said it perfectly. A warm
Excellent.
hello to everyone. I have to say, Georgia is one of my favorite states. I had the opportunity to go there a few times, so I was really excited to be on the phone with all of you today. So as discussed, we're just going to spend about 15 minutes and going over just kind of what the basic principles of continuous glucose monitoring is, then talk a little bit about opportunities to expand coverage for the Georgia Medicaid population. And then I'm going to turn it over to Dr. Galindo. Dr. Galindo is an endocrinologist in the state of Georgia, and he'll be talking a little bit more about the benefits around CGM. And then we'll end with some Q&A, some questions and answers. So I look forward to having a nice discussion. So I'm just going to begin just by kind of talking about the basic principles of continuous glucose monitoring, also known as CGM. So these principles really apply to most CGMs on the market. The devices have a sensor where there's a thin filament that lays under the patient's skin. The filament measures glucose levels in interstitial fluid. And then the glucose level is transmitted either to a reader or to a app on a cell phone. So it was really great to hear about what's coming down to the state of Georgia in terms of access to smartphones. So either can be used. Each graph, each reader, no matter what you're using, device for all systems, show the current glucose level that the patient is now, as well as trend arrows to indicate the direction that the patient's glucose level is moving, and a retrospective graph of like 8 to 12 hours. So with that, will you be showing my slides or should I share my screen? I kind of saw them there. Would you like?
Ms. Bibbs, will you be controlling the slides or are you going to send
well, someone has taken over the screen.
Yeah, I saw my slides jump up, so okay, perfect. Okay, so this is just a really quick overview of the indications of the Freestyle Libre 2. So it's a real-time glucose, continuous glucose monitor. It has optional alarms. It's indicated for the management of diabetes for people age 4 and older, and it is designed to replace blood glucose checking for diabetes treatment decisions. The Freestyle Libre 2 has the lowest wholesale acquisition cost because it's always been Abbott's intention to make the Freestyle Libre 2 system affordable to all. So if you could just go to the next slide. And this is current state in the state of Georgia. So 1.8 million Medicaid members are enrolled. Out of that, approximately 189,000 Medicaid patients are living with diabetes. Diabetes prevalence, as we all know, is higher in the Medicaid population. It's a challenging, higher risk population to manage. A lot of these participants have access to care issues, transportation issues, secondary to social determinants of health. Medical expenses for people living with diabetes is about 2 to 3 times higher. And in the state of Georgia right now, there's 65 in-network endocrinologists. If you could please move to the next slide. So the Georgia Medicaid policy is actually very progressive. It covers CGM for people on multiple daily injections for both type 1 and type 2. Currently, it is required that an endocrinologist writes the prescription for CGM. So 90% of all patients living with diabetes are typically treated by primary care physicians. That's kind of a well-known statistic that has been around and endorsed by the NIH, CDC, ADA. So currently, there is a gap between the providers who are treating the patients living with diabetes and the providers who can actually prescribe the CGM. If you can please go to the next slide. Great, thank you. So this is the Diabetes Healthcare Reform Consensus Statement. This was published November of 2020. A couple of the national thought leader organizations got together to publish this. And the goal of this consensus was really to address health inequities and to identify and prioritize coverage improvements. So one of the things that they called out is that all diabetes coverage determinations should be adjudicated within 24 to 72 hours. They identified this as really being the best practice. So currently here in the state of Georgia, CGM is covered through DME benefit opposed to pharmacy benefit. So because of prior authorizations, there is a significant delay in getting the patient the CGM once it's ordered. So from a patient engagement, patient empowerment perspective, we know that that is the cornerstone, right, for improving quality of care. So having that delay in the adjudication of coverage can impede upon the patient actually starting the CGM in a timely fashion or at all. So next slide, please. So I'm going to shift a little bit and just kind of highlight where's the added value with CGM, right? Finger stick has been the gold standard for treating diabetes for a very long time, but we know there's barriers to it, right? 1 out of 3 patients, they say adhere to it. 2 out of 3 patients report skipping doing finger sticks, and less than 1 out of 4 patients using insulin actually achieve the target goal of less than 7. Blood glucose monitoring is how I explain it to patients. It's like looking at pictures. It's a snapshot in time. CGM actually is like a video. It gives you all the information, right? So there's no gaps for either low blood sugars or high blood sugars. In addition, I just want to highlight that in the ADA 2021 guidelines this year, they actually changed HbA1c metrics to be glycemic metrics. I thought that was extremely telling around the endorsement of the added value for CGM. Because they wanted to include those individualized metrics that A1Cs cannot give, like time and range, that really improves patient care. So without the utilization of a CGM, you can't really adhere to what the ADA has been advocating for. So next slide, please. Just a really quick high-level overview of some of the clinical data that has been coming out from randomized control studies, real-world studies, meta-analysis, right? We've been able to show statistical significance in the reduction of hypoglycemic events, time in hypoglycemia, and we know that hypoglycemia is one of the leading causes of avoidable ED utilizations, which is a quality metric, right? Increased time in range, decrease in A1C, again, alignment with quality metrics, as well as a decrease in resource utilization like hospitalizations. Okay. Second to last slide, please. Great, thank you. So this is a study that was just published by Miller and colleagues in 2020. And it looked at the type 1 diabetes exchange clinical registry. And 2 of the things that they called out is they wanted to see, has there been improvement in A1C levels with the use of CGM in participants that have state and federal insurance, as well as those from lower socioeconomic households? And both groups were able to show a statistical significance and improvement in A1C levels with the utilization of this technology. Okay, and my final slide is just some key takeaways, right? There's a growing body of evidence that really supports the use of continuous glucose monitoring. Covering continuous glucose monitoring in the pharmacy can improve timely access to care, as well as can lead to cost savings for Georgia Medicaid. So with that, I am going to pause and turn it over to Dr. Galindo.
Hi, good morning. I just want to ask, do you see my presentation?
Yes, we do.
Yes, it's present.
On my face?
Yes, we do.
All right. So I want to thank the committee, the Department of Community Health of the Georgia Medicaid program, and I also want to thank the Abbott team for partnering with me and this group of clinicians on this initiative. There will be some repetitions on the slides just because they did not. This is an independent presentation that we prepare as a group of expert diabetologists in the state. But we work together on this. This has been a long way process. So basically, we want to change or modify, if possible, the way we provide CGM to Medicaid patients that we see in our practices. And here I had the names of all the clinicians. So Dr. Bruce Bodie, James Gavin, Candy Nobles, Kate Wheeler, Jessica Hutchins, she's a pediatrics endocrinologist, Kim Sinclair, Ann Blair, they're diabetes educators. So the next slide is my disclosures. So I have funding for research. I work at Emory University and I have funding for research to Emory University and have done consultant work for many companies. And I also have NIH funding. I think this is important to know. I'm a member of the National American Association of Clinical Endocrinologists guideline for diabetes care, and I was the first author of the consensus statement of the use of CGM and diabetes technology in the hospital. I will not be discussing these two guidelines today. We're going to review very briefly the technology again. As I say, this is an independent presentation. What the CMS, the Medicare coverage, and the Georgia Medicaid coverage is. So I just want to bring your attention to how much we have advanced since we started checking humans' glucose. So back in the 1900s, we started using the urine analysis, and they still in some countries in Africa, and the medical students, when they go to Africa, they come back fascinated that they still adjust insulin based on that. But we have advanced, I lost my mouse. We have advanced, we have advanced a lot, and we have now continuous glucose monitoring. We're on the third generation. The next step is what is called non-invasive, meaning that these sensors still have minimal invasive contact. And here I'm gonna just, this is a schematic representation of what a CGM is. So basically, as you see at the bottom is a blood vessel, and then glucose molecules in the blood vessels. So when we check venous blood glucose, this is what we measure. That glucose, it goes into the interstitial tissue, which is below the skin, and there are cells there. And as you see, there is a small catheter that the sensor has inside this tissue. So it's very thin, it's very small, and then there is a sensor that convert that that measure a reaction, a glucose oxidase reaction by some meters, and another reaction by other meters, by other sensors. And then that reaction generates an electrical current, and that current is transmitted to numbers by the sensor. And then some sensors have attached a transmitter, and there is another receiver on a smartphone. So what I want you to understand is that there is a physiologic delay in the transfer of blood sugars, of glucose from the blood vessels to the interstitial tissue. But when we use CGMs, we never focus anymore on one point of care glucose value. We focus on the direction, on the patterns, the tendency, the rate of change, the speed of change. Is it dropping too fast? Is it going too high? So we're no longer focusing on the 135. We're focusing on the 135 going down. So, and this is what we have on a daily basis in our offices, a woman who is on insulin checking 4 times a day, 5 times a day, which is a lot of work for a patient. And she brings this little box that we have used over 20 years. We can get a lot of information, but it's still not really the full picture. When you plot these into some softwares that can give you those 4 points in a plotted diagram, you get a better idea. But when you do a CGM, you get this picture. And as you can see, the 4 point of care did not show us the drop in the glucose at midday, nor show the spike in the glucose to above 300 before that lunch. So So I want to say, I thank you very much, Avo, for partnering with me on this, but there are more than one sensor in the market. There are 4. So Freestyle Libre, the first one was Pro, then Libre 10 days, and now Libre 2 and Libre 3. The committee that presented may not know because they are not in the scientific area, but of the Avo, but the Libre 3 is coming, or they may know. So Dexcom had G4, G5, now G6, and G7 is coming as well. And then we have Medtronic. They have been in the market for a long time. And then we have Eversense, which is a little bit different in a sense that it is implantable. So you need to do a small incision. It's done in the office and the patient goes home the same moment. So overall, they are approved from a range of age. And the big difference is whether the sensor communicate with insulin pumps and create what we know now by artificial pancreas. The FDA doesn't like that term. They prefer automated insulin delivery system. Anyway, so this is a review article we published, and at the bottom are the pumps that sensors can connect to. So this is how they look. So Abbott, they have presented, is very simple, very easy to use. Patients found it very easy to use. Libre 2 have an option for real-time alerts when the sugar goes up and down. The patient needs to activate that alarm, and the patient needs to be willing to scan to get the reading. If the patient does not scan, they don't get the real time. So Dexcom G6 does have real-time data transmission, and they have something that is being changing to patients in terms of hypoglycemia. It's called predictive early low soon alarm. Basically, the sensor will predict 20 minutes, 30 minutes in advance if the glucose is going to be below a threshold of 54 or below. And it connects with these 2 pump systems, the T-Slim and the Omnipod. So I divided in these 2, which don't require capillary glucose calibration, which is something to applaud Avo for coming up as the first one in that category. So basically, patients do not, and I will repeat this 3 times because it has to do with the current criteria for coverage. The sensor will provide continuous glucose monitoring without the need for the patient to check glucose, capillary glucose. The patient do not need to check capillary glucose. These 2 sensors, Abbott, Libre, and Dexcom, don't need it. Medtronic still needs it. They also have real-time and predicted early low soon, but if the patient don't check capillary glucoses for confirmation, it will not function. And then Eversense also needs that calibration. And as I said, Eversense requires a small incision in the upper arm. There are only a few providers in the state that can do these, and the company last year didn't have too much support. They are coming back. It is needs to be changed every 90 days. It will be changed every 180 days soon. So I want to also show this study to say how much we have changed in the way we work with diabetes. This is just basically showing 2 lines, blue and red. I mean, there are 4 groups, but I want to call the attention of the red and blue. What it's showing is that the difference is not the insulin pump or the injections or the way the patient is doing it. The difference is whether the patient is using a sensor or not. Here in red are patients using insulin pump or injections and checking capillary glucoses. In blue are patients using real-time CGM on pumps or injections. And as you see, the A1C came down on the blue using sensor. The A1C did not improve on those using injections. Capillary glucose. This is the current CGM criteria by CMS. As you see, they need to have diabetes, 4-finger sticks, injection of insulin, intensive, so many requirements. So we have published this document and we have presented to Medicare. In January, there was an opening for comments, and then we had a special meeting request with them, this group of clinicians in the country, including the president-elect of the American Diabetes Association and some past presidents as well. We met with Medicare and we proposed new criteria. Of course, they are revising their criteria, and we truly hope they're going to change it. This is the newly proposed CGM criteria that we recommended. Going back here, these 2 points, Medicare already in their letter to their country in January said they will remove Medicare, and I will repeat, Medicare is removing the 4 times daily finger stick requirement and the injections. There were injections, by the way, there is one insulin that is not injectable, so those patients will never get a CGM. So they're removing that, and this is our proposed criteria. So diagnosis of diabetes type 1, type 2 on insulin, type 2 with hypoglycemia, advanced chronic kidney disease at risk of hypoglycemia. In this population, the A1C is not reliable. It does not give any information. And the use of in-person or telemedicine consultation before initiation and must follow up. This is the current CGM criteria by Georgia State. You guys review these. The key points here are the endocrinologist, the diabetes and more than 3 injections and hypoglycemia or prior use of insulin pump or CGM. The required documentation is very extensive, creating a lot of burden. And the expectation is that patient will have more than 80% compliance with the CGM. I think this has to do with the prior CGM requiring capillary glucose monitoring to really be effective. The new CGMs do not require that. This is, we are preparing a letter that we'll be happy to send to the chair of the committee. This group of clinicians, the letter is written, so we just need information to submit it, and we're planning to publish this as a peer review publication. We suggest the following modifications, and the reasoning is mainly for Medicaid patients, is just creating more disparities. So the requirement of having an endocrinologist is limiting the provider to 64 in the state. I just had an email from a pediatric endocrinologist who sees Medicaid patients, and she barely told me, I need to spend, or my staff need to spend 30 to 1 hour minutes on preparing the paperwork. So I know that other pediatric endocrinologists don't spend the time. So basically, if they need to spend time, they will not put the extra work, and patients are just suffering for that. So we truly believe that this is not helping patients and is limiting access to a game-changing therapy. We suggest a reduction in simplification of the recommendation requirements. We also suggest modifying the requirement for prior CGM training. It would be very hard to train somebody when they don't have the device. The current blood glucose monitoring frequency have no scientific evidence to support. That has to do with the old technology. The new technology, we have plenty of studies, and the letter will show you evidence with plenty of studies, about 10 to 12 studies. Similarly, current insulin requirement, the 3 injections are not more risky than just 1 injection in determined, in the different scenarios. So modify the requirement for improvement in diabetes control. So specifically for Medicaid patients, it is not just showing that they will get better. So the point is that they will not get worse. And if you remove this therapy, they may actually get worse because they will not have the benefits. Inclusion of telemedicine is possible. So we have many patients that live in rural areas and there are no specialists in those areas. Allow CGM acquisition to a better way, simplify mechanism through pharmacy. And of course, as I show you, the future of at least type 1 diabetes will be the combination of these hybrid artificial pancreas closed loop systems, where the CGMs talk to the insulin pump and the insulin pump give insulin as needed, or when it's not needed, stop giving insulin. So the use of FDA-approved artificial pancreas will be key for that population. And of course, consider the new proposed criteria. This is basically what we're going to write on the letter. These are my titles and my emails. I will be more than happy to take questions, and many of the members of the committees are also in the phone calls. So if you guys have any questions, we will be happy to answer. The Abbott team is also ready for questions. Thank you very much to all of you, and it's been a pleasure to advocate for our patients. All my colleagues represent that too.
Thank you, Dr. Galindo. From the Abbott team, is there anybody else that has any other presentation, or should I go ahead and open it up for questions?
No, please open it up. Thank you.
Okay. Well, first of all, thank you very, very much, Dr. Galindo and Dr. Tito. I will tell you that diabetes, and we all know this, is chronic illness that affects so many. And I'm hearing an echo, and I'm not sure why. But nonetheless, I'll go on ahead. But anyway, I wanted to go ahead and open up for questions, because the goal for this committee is to make sure that we are overseeing DCH and helping to assist all of our Georgians with chronic illnesses to improve access and quality of life, and be able to have decrease our ER visits and improve outcomes. So this is really exciting. I'm going to open it up for questions. for me, I appreciated the physiology review, so thank you very much. Can I ask, currently, what is the process is covered by the DME program? And the ask is that we can save money for the state if it's covered under the pharmacy program. Is that correct? Oh, you're on mute.
Carl, can you please take that question?
Yes, hi, this is Carl Slivka. I work with Abbott Diabetes Care as the Director of Market Access. The answer on that is yes. The DME, typically the fee schedule is established by the state or Medicare as a guideline. And in many cases, the WAC pricing of these products are less expensive to adjudicate at retail. And in doing so, we believe that there's a significant savings to be had for the state, for the state. And it simplifies access for both the physician from a prescribing perspective, as well as the ability for the patient to walk into a retail pharmacy where most commercial patients today cover or receive their CGM products. It would just make it easier and more timely, let's put it that way, because on the DME side, it can take up to 2 weeks by the time the paperwork gets processed, gets sent over. Then you have to do the training, bring a patient back into an office, et cetera, for some of the devices. So simplifying that process would be a way to go.
Absolutely. I mean, I would think, especially for
Hi,
our
can I make
children,
a comment?
that one second, that having access to the device when they're hospitalized, getting that training while they're in the hospital is the way to ensure success. So there's delays now getting it through the DME. If you get it through the pharmacy program, the patient will be able to have that sooner and be able to be trained, I guess, better.
Right
Is that
there.
correct?
Correct.
Okay. Somebody
Dr.
else.
Belinda, you wanted to say something?
So I wanted to say, so I don't know if the Abbott team actually have prescribed a sensor. I don't know if they're allowed to do that. So the experience they have is from Cummins. So this is more complex than just cost, right? So I don't know if the state is just focused on cost. I think this is just focused on patient care. Let me just give you a simple question. Abbott is about $60 cash. So if you have a patient who had the $60, they will go tomorrow and buy it. If you have to go through Medicaid, the provider will not spend the time. So this is just creating disparities by not having a simplified process, because first, we only have 64 endocrinologists in the state able to prescribe it. So out of the whatever millions of patients we have with diabetes, there are only 64 people allowed to do this, right? Who are these people? The poor people, the people in the rural areas, the sick patients that don't have access, and then the patient that will really benefit from this because they keep coming back to the hospital with diabetes ketoacidosis, or they keep having hypoglycemia. So if I'm a Medicaid provider and I need to see a patient for 30 minutes and doing the paperwork for DME takes 30 to 1 hour, I either need to spend money or hire an extra nurse, which I don't have the money for, or don't do it because I don't have the time. So the people that really suffer with this is Medicaid, the poor people, because nobody gonna put the extra life on this if this is taking their life. You see what I'm saying? So it's more complex than that. It's not just I prescribe it when you're in the hospital. In reality, I'm not sure if the prescription at the hospital is the right place. This patient would get 20 new prescriptions, right? I think that anywhere where the patient is using injections or have uncontrolled diabetes, they should be able to get the device and get a training. The training, I would have a training module that is 1 minute. So you can get training 1 minute. I mean, it takes some practice, but they have created videos that it lasts 1 minute. So I think that it goes beyond cost. I think that it goes into eliminating disparities, right? And I don't have scientific studies in the state of Georgia, but there are studies in Europe. And Abbott had also shown some studies on the prevention of admission for diabetes ketoacidosis and prevention of admissions of hypoglycemia. But in Europe, where they have systems where patients are it's universal healthcare system that has shown decreased cost. So I don't know if I made it more complex, but I wanted to say this is more complex than just what they, I mean, they are I work with them every day. We use it in our practice. I think their devices are really good, but this goes beyond just I can give it to you. This is like just creating. This pediatric endocrinology from Macon told me I basically cannot spend the time or prescribe the CGM to my patient because otherwise I will not be able to see them.
No, thank you, Dr. Galindo. I completely agree with you. It is far more than cost. And really, at the end of the day, our goal and our purpose of this committee is to make sure that we're implementing policies that overall helps the quality of care and life for our Georgians on the medical assistance program. So what is, one more time, I'm going to open it up for questions. And I believe Peter Dalba is on the call as well. Is there anything that you can add, being the pharmacy lead for the state?
Sure, I'd be happy to. So just a couple of questions, or a couple of comments rather. In terms of the cost, I believe the Abbott representative had said that it would be cheaper on the pharmacy side. I'd like to clarify and say that is incorrect for us. We have a state plan amendment that allows us to reimburse durable medical equipment at 80% of the CMS rate. And so it would be 80%, whether it be on the medical side or on the pharmacy side for us. In terms of being able to expedite more efficiently on the pharmacy side versus the medical benefit side, for all durable medical equipment, whether we would have it on the pharmacy side or the medical side, we allow for a 30-day review time on either side for all medical equipment. It's just standard for what we have, and so that wouldn't change on either side. So that actually clarifies that. The other thing that we didn't mention here is that there are a large number of members who, outside the Abbott product, this is very Abbott focused and not necessarily looking at just CGMs in general, is many of our members do have insulin pumps where those members actually benefit from an alternative than the CGM that Abbott is offering. And so we need to look at that model as well. And so for consistency for us, all CGMs do run through the DME benefit and not on the pharmacy side.
So you'll just have to educate me a little bit. So when I have a patient that I've seen here in the office that looks like they're in diabetic ketoacidosis, I send them to the ER, they get hospitalized for an extended period of time, and they're learning for the first time a chronic illness that they'll live with every second of their life. So at that point, so much teaching happens while they're in the hospital, but is that true that then they don't even have the device to be able to manage their disease for 30 days?
No.
Is it like that in the private sector? Because then there is a disparity.
I don't think there's a disparity in the private sector. We allow for 30 days, but our turnaround time is generally between 5 and 7 days for a durable medical equipment. And in fact, some people that are in a hospital, if the service is there, we have providers that will actually work with the hospitals to discharge a member on a piece of medical equipment, not only just a CGM, it could be a wheelchair if it's needed or whatever, oxygen. We don't let a member go out of the hospital without the medical equipment that they need. So from that perspective, if you're going to be discharged from a hospital, we have providers that can turn that around relatively quickly if that is the case. In the private practice setting, yes, it does take some time to do the paperwork for that prior authorization. Whether it be on the pharmacy side or the medical benefit side, the requirements would be the same for us. The paperwork it would not change on either side. We do require that they provide that documentation, and we do turn it around relatively quickly on the medical side.
Thank you for your input. I think for me, what I'd like to see is we are always so used to saying, well, this is how we used to do it, and I want to make sure that as our committee that I encourage, the DC, the Department of Community Health, and the medical assistance plans to always look for a cleaner way to do things going forward. The
Absolutely, I
administrative
agree.
burden we know is extraordinary. And I know that in other areas, especially with certain medications in other fields, the you've been able to make it easier to do those prior authorizations and making sure that we can get care to our patients when they need it. So I just encourage and want to make sure that we're always still doing the same. Let's try to make it easier. We don't need to do it like we used to do it, because we've been doing it the same way before. Because I think that would definitely make it easier for primary care physicians who are taking care of these diabetics until they're waiting to see their endocrinologist. So that's helpful. Thank you.
Dr. Shed, can I make a comment just really quickly? I know you guys are tight on time.
No, go ahead.
I think that one point about the DME is it's not just one DME company. It's several of them, and all of them interpret the guidance in different ways. So every single DME company, we have a different criteria on the way they interpret the regulations. So the amount of documentation required for every DME company is complex and sometimes differ. So not everybody will interpret your guidance in the same way. So that is creating some sort of confusion for providers there. And the other point is, while I agree that insurance patients get CGM faster than Medicaid and they just get it within like 5 days, Medicaid takes some time. I don't think that that would be the only focus of discussion. I think that there are important keys in the way it's covered right now, which is limiting only to endocrinology. So per our review, there are only 64 people allowed to do this in the state, right? Second, endocrinology is only, that would never really serve the purpose of helping patients with diabetes, because we cannot provide diabetes care for all patients. We need to have the help of the primary care physicians, right? So the other point is the criteria of the 4 finger sticks per day based on science is not supported on randomized controlled trials, nor is needed for the device. So that really doesn't really help patients. Basically what they do, they will do it for a week, get the sensor and don't do it. So because it's not needed, they don't need to do it. And then also the requirement of the multiple injections of insulin is just basically not. So the future is, anyway, so those are not based on science. I know that you're rushing on time, and thank you so much for the opportunity.
No, I appreciate that. So I think the next step is, I thank you very much for presenting this to our group. So Dr. Holloway, what would be the next step as far as looking at care pathways and ways to make sure that we're always moving forward with as far as diabetic care?
No, thank you. And also I want to thank the presenters. It's extremely helpful and good conversation. What I would suggest, Dr. Seth, is that we consider the committee taking into consideration the recommendations that are being provided as relates to changes that Dr. Galeno suggested. I think what we can add to that conversation, be it from DCH, is to provide kind of a brief value analysis, be it in terms of what exists now as to what's proposed, be it pertaining to the medical side or pharmacy side, taking a whole look at the entire value equation, quality as well as the cost, the abrasion, not just for physicians, but also outcomes, and share that with the committee so you can have a holistic perspective. And then your body consider some recommendation to DCH after having that information to kind of vet. That would be my suggestion and thought.
Okay, that would be, yeah, it's a big process. So that would the next step be for them to then send their letter? I think I'm seeing somebody typing something here. Share the letter with us. Okay.
I was just asking if we are provided with a way to share this letter, and this will be a peer review publication at some point. And I can also share the Medicare letter that we share with Medicare and the publication. So we will be happy to provide that if we are provided with some sort of contact. My email is at the end of the presentation.
Got it. No, thank you. And I think we've got access to that as well. So that, I guess that would be the next step, is for you all to do your recommendations, and then we can take that internally. And Dr. Holloway, you can help us make sure that it gets to the right form so that we can properly vet and make the whatever necessary changes are so that we can, at the end of the day, provide better care for our Georgians. Anybody else have any other comments regarding CGM? Thank you, Abbott. Thank you for the entire team, Dr. Galindo. It was an excellent presentation. I learned a lot. It was a good refresher course for me. I'm going to take a second.
Dr. Chef?
Yes.
This is Stephen Trias. Hello, everyone. I have a question in regards to the Freestyle Libre. My question is it better to use the app on your phone or to get the actual device to monitor your glucose readings? And I think that message could be for Marie.
Yep, sure. I could take that question. Thank you. Thank you for asking. So it really depends on patient preference. The Freestyle Libre 14-day has a reader and an app, so the patient has the choice. The Freestyle Libre 2 right now has a reader, and we're waiting. The app is approved in Europe and Canada because of COVID. It's a little bit of delay here in the US, but it will be coming soon. But both of them allows the reader or the app shows the same information, the current glucose level, the retrospective graph, and the trend arrows. So it's really a patient's preference as to what they like to use.
Okay, do the apps show anything different from the actual reader or vice versa? Does the reader give you more information than the app?
Yep. No, it's the same information, and they both can be uploaded into our Libre View. What is of value with the app is that if you use the app, it goes straight away into the Libre View, which you can use to share the data with your provider or caregivers. If you choose to use the reader for your own preference, you then have to download the data into the Freestyle Libre View. So there's an extra step in terms of sharing it in the Libre View if you choose to do that, if you use the reader. But in terms of the glucose metrics, which I think is really your question, it's the same. You get the same glucometric access, which would be time and range, different reports that we have and so on, on both.
Okay, thank you so much.
You're welcome.
Great, thank you. So we'll just allow you all to send that information to me. I think you have my email, and then I can pass it on to the proper people within the plan to vet and move forward. Are there any announcements? Is there a quality strategy, Dr. Holloway?
Just an update to keep you apprised of the process. The quality strategy was posted to our website for public comments through the month of April. Very good response from the advocacy community and others. We have since incorporated those that we felt were warranted and have now submitted the strategy to CMS the first part of this week. We will keep you apprised of their feedback and response, but we are excited of having coming to this vital juncture and updating our quality strategy. That's the only announcement I have, Dr. Seth, other than the next meeting for the third quarter that's on the agenda.
Yes, thank you very much. So the next, is anybody else have anything else they want to add? Because otherwise we'll close it up.
This is Laura. Can you guys hear me? I had to move from Teams to the phone because my computer is being mad at me.
Go ahead, we can.
Great. I know that the managed care organization rebid process, I believe, is scheduled for sometime in 2022. And while I know there's lots of CMO representation on this body, I'd be interested in hearing from DCH at a future meeting about how members and consumer groups can help to inform that process and make sure that the procurement documents and process kind of reflect the needs of Medicaid members themselves. So I just wanted to put that as a proposed topic for a future meeting.
Thank you. If you can, that would be great. If you can just email that to us, that would be great, so we can make sure that we can do that. Hearing no other additions, I think I'll go ahead and adjourn this meeting and go ahead and let everybody get ready to see us in the heat of summer, August 18th, 2021. And as far as location, who knows? It might be on Teams, or it may be in person. We'll see how that goes. But otherwise, everybody enjoy your day. Thank you so much for your participation, and thank you for our guest speakers today.
Thank you.
Thank you.
Thank you.
Thank you.
Stop.
Bruce, I need you to disconnect from this meeting.